Good morning, Dr. Dias.
How are you?
Very well, sir. How are you?
Doing well, doing well.
Excellent. Good.
I don't.
Hello, hi, Arjun. Hello, Doctor. Good afternoon, Dr. Tebow.
Hello, Naren. Nice to see you.
Our pleasure is privilege is mine. Thank you, sir. Thank you, Richard. And we have Dr. Dias. Can I please introduce to our two panelists, Dr. Dias?
Absolutely. I'm all set. So
Good. This Mr. Richard Edwards. He's our clinical lead for neurosurgery at Bristol, and he has got a very strong interest in non-accidental injury. He's the past president of the British Pediatric Neurosurgery Group and the current chairman of the British Hydrocephalus Society. And Dr. Jeff Tebow, he's from Birmingham Children's Hospital. I used to work there, and it's a very busy hospital, particularly when it comes to non-accidental injury. Dr. Jeff Tebow, if I'm not wrong, is a pediatrician with an international reputation on non-accidental injury from the pediatric side. So it's great to have you both, so we can be enlightened with your discussions as well.
It's Birmingham, UK, not Birmingham, Alabama.
I'm familiar with both.
Oh, excellent.
I've been to Birmingham, England. So
oh, good.
Excellent. Well,
I've also been to Birmingham, Alabama. They're not anywhere near alike.
Did you know Mr. Hockley, did you, when you were in Birmingham, the neurosurgeon?
Did I meet Mr. Hockley?
Yeah.
No, I was in Birmingham for an international child abuse conference there, probably 15 years ago now.
Right.
So I was there on behalf of the child abuse pediatrician group, and I never really met any of the neurosurgeons.
All right. No.
Dr. Mark Dias was meant to come in 2020. We had this neurosurgery collaborative meeting. It was just a week before the pandemic shut everything off. So, so as soon as the pandemic has any sort of control, then we'll have hopefully one in Bristol. It was a really good one, Richard. We had it in Copenhagen, and it was like the PING meeting, but it was a pretty international. And PING meeting was the Pediatric Informal Neurosurgery Group meeting that the British and the French neurosurgeons used to have. And they alternated between the two countries when it was Dr. Hockley and the old great French pediatric neurosurgeons. So we had this collaborative meeting using that template, but it involved complex cases, complications, as well as research projects. We had it in Copenhagen and then went for a dinner at the Parliament, which was really sweet. Great. So we are now just after 2 o'clock. Thank you very much to everyone for attending this, what you will find very useful and also very engaging lecture from Dr. Mark Dias. Before I introduce Dr. Mark Dias, I want to introduce you to two of our expert panelists who will help us to tease out the problems by discussing with Dr. Mark Dias the controversial areas and also ask Dr. Mark Dias some questions. Certainly the questions will be open to the participants. So if you wish to ask any questions to Dr. Mark Dias or to Dr. Mr. Richard Edwards or Dr. Jeff Tebow, please put it on the chat box and I will open the microphone to you. I want this to be pretty interactive. And Dr. Mark Dias has an encyclopedic knowledge on non-accidental injury. He has well published on this field, and also he used to run the biennial every 2-year meeting on non-accidental injury at Penn State, which was an important meeting. First of all, Mr. Richard Edwards, he's the clinical lead of the Department of Pediatric Neurosurgery at Bristol Royal Children's Hospital. He has a particular interest in non-accidental injuries. He's a past president of the British Pediatric Neurosurgery Group and currently the chairman of the British Hydrocephalus Group. So it's a great honor to have him. And we also are privileged to have Dr. Jeff Dibble. He's a pediatrician and the lead, co-lead or lead for the child protection at Birmingham. It's a very big center which deals with a lot of non-accidental injuries. I had the privilege of working there, and he brings a wealth of experience and a world-class expertise in this field. Our invited speaker is Dr. Mark Dias. He's professor and vice chairman of the Department of Neurosurgery at Penn State University. And he has wide interest, but 2 areas of his particular interest are non-accidental injuries and dystrophisms. We had a lecture from Dr. Mark Dias on dystrophism, an excellent lecture a few months ago. So it's really an honor to have Dr. Mark Dias again here at this meeting. Once again, I'm an affiliate faculty of his department as well. So in some ways, this is those places I am associated, but all 3 are world class. So Dr. Mark Dias, without further ado, may I please invite you to deliver your lecture, and we are all looking forward to it. And as Dr. Mark Dias start, please, if you check the chat box, I have put a link where if you click it, then it will take you to a Google form and it will ask you for your email address and name. And if you fill it, you will automatically send a certificate of attendance. Thank you very much, Dr. Mark Dias.
Thank you, Naren. And I hope, can you just confirm with me that my slides are projecting okay?
Yes, absolutely.
Okay. I've had some weird experiences when I've had my slides project, particularly when I have 2 monitors. They don't project correctly. So
you can maximize it for us, Dr. Dias, as in presentation mode. At the moment, we are seeing that.
Is that okay? You can see it okay now in presentation mode?
We are just seeing as it were you are creating the PowerPoint. I think you just need to click on that slideshow mode.
Yeah, I did that. Let me just do it.
Otherwise, it's coming across clearly.
Is it in presentation mode now?
It is. Yes, I think it's going to come up. We can see this. I think it's probably the 2. When you have 2 screens, usually this happens. We can see very clearly as it is.
Yeah, I eliminated my little thumbnails.
Okay, brilliant. That's for sure.
Just ignore the stuff at the top then.
Thanks.
So I've given a number of different talks on labeled concepts, controversies, and conspiracy theories. In the interest of time, because I could spend a whole hour on any one of these, but I've kind of eliminated the conspiracy theories, but I'm happy to talk about them in the question and answer forum. So first of all, I think we need to be clear about the nomenclature. There have been a number of terms applied to this entity, and we've really sort of centered, for the most part at this point, on the concept of abusive head trauma. Sometimes people refer to non-accidental injury, NAI, or non-accidental trauma, NAT, but that's sort of a much more generic classification for injuries rather than head injuries in particular. So I'm going to use abusive head trauma. In particular, I think that we should really stop using the term shaken baby syndrome. These terms are grayed out here. Not because, and as you'll see, I'm an advocate that shaking actually can cause brain injury. And some of the more controversial things I think I'll present speak to that. But the bottom line is that in any particular case, if we don't have evidence of blunt force trauma to the head, we don't know whether it is shaking, impact, or both. And so, and I think people have gotten into trouble. I've seen people get into trouble testifying in court in cases where there's clear-cut evidence of blunt force trauma to the head, and they call it shaken baby syndrome, which is crazy because that's blunt force trauma to the head. There's evidence of that. There's skull fracture, there's cephalohematomas, and so on. So the American Academy of Pediatrics has recommended that we use abusive head trauma simply because in any particular case, we don't know what the mechanism is. And just to give you a historical perspective on this, what really amounts to a controversy without a controversy, I think. But in Norman Guthkelch, who actually was one of my mentors when I started residency at the University of Pittsburgh, Norman Guthkelch and then Caffey, then at the University of Pittsburgh, 1974 described, was the first recorded description of a shaken baby syndrome, although they didn't call it that, but it rapidly came into common use as shaken baby syndrome. 1978, Tinahain, as probably everybody on the call knows, had a sentinel study, and I'll review that in just a few minutes, in which she coined the term shaken impact syndrome and described the importance of impact in these injuries. In the 1980s, of course, there were a number of studies that came out that suggested that impact is an important part of this syndrome, arising in 20 to 63% of patients, even those in whom only shaking was described. In the 1990s, this led to a backlash against shaking as a potential mechanism of injury. And that force began to mount, and I'll talk about that in just a second. And that led at the turn of this century to this whole concept that the term shaken baby syndrome is actually a myth, and that it's based on inadequate or false science. And then in the 2010s, at least in the US, there have been multiple cases seeking post-conviction relief. Those people who were previously convicted of abusive head trauma seeking post-conviction relief. And it's really become the next sort of innocence project after the DNA stuff that came out earlier. And this is just a snapshot of a number of different things that have appeared in the media. You can see in USA Today, this one here from NBC News, wrongly accused of shaken baby abuse, case puts focus on legal debate. And a number of these have come out. A new film challenges shaken baby syndrome in courts controversy. Interestingly, the Medill Justice Project from Northwestern University, this is the Medill is the College of Journalism. I always thought journalists were supposed to be unbiased and objective, but so I thought it was sort of a weird thing that a journalism school, a college, would have a justice project where they take such a huge advocacy role. But that's an interesting. It says in pursuit of the truth. And then even in the Supreme Court of the United States, this case was actually decided in the opposite direction. But the dissenting view, which was led by Justice Ruth Bader Ginsberg, of all people, really cast doubt on this whole issue of shaking as a mechanism for abusive head trauma. And I won't go into the references that they use, which really are very shaky on shaky grounds. So how did we get to this controversy? And I just want to briefly go over sort of my view of it. This began in the 70s at the University of Pennsylvania, pretty much, and a group of neurosurgeons, many of whom are familiar on this call are familiar with, generally Tebow Omaya and their group took adult, and these were folks who were were looking at head trauma in general. They weren't looking at abusive head trauma. So these were a series of experiments performed on adult monkeys who were put on sleds with their heads either immobilized or allowed to move freely. They accelerated the monkeys on the sleds so that there was no impact injury to the head. There was a piston that shot the sled forward, and the adult monkeys' heads, if they were left unrestrained, would whip backward, and the acceleration was 5 to 30 milliseconds. And as I said, either the head immobilized or allowed to rotate. And of course, if they're immobilized, they had primarily linear accelerations. If their head was not immobilized, they had angular accelerations. And they used 3 different primate species having different sized brains, brain masses. And they established thresholds for concussion, subdural hematoma, and axonal injury for each species. And then they extrapolated that based on to humans based solely on mass scaling. In other words, they in this recreation of their graph, they just simply put down the points for each of these 3 species of monkey, and they said, well, man's brain is going to be this mass, and therefore it's going to be that's where they'll fall on the curve. And so it's important to understand that this was extrapolated to adult brains at the time based on these 3 primate models. Tinahain in 1978 undertook the first attempt to try and model abusive head trauma, abusive shaking and impact using a biofidelic doll model. I put that in quotes. Because it's not very biofidelic. It was the first model that had a lot of problems with it, particularly with respect to the stiffness of the neck. And they subjected these dolls to shaking, and they got Penn students, University of Pennsylvania students, I think it was athletes, football players, to shake these models as hard as they could. And they measured via accelerometers the amount of acceleration to the head. And they did that with shaking, and then they also had these volunteers smack the doll against an object representing an impact. And basically what they concluded was that shaking alone didn't come close to reaching injury thresholds for subdural or traumatic axonal injury, but that impact exceeded the thresholds for both. And there have been a number of other studies that have used other models. Carol Jenny, a very well-known child abuse pediatrician who collaborated with Aprika in Japan and developed another model, has gotten much closer to injury thresholds using different parameters for her model, and so on. And so there have been a number of other people trying to figure out if we can create a model that allows for the acceleration to get to injury thresholds. And this is taken from Tinahain's paper, adapted from Tinahain's paper. And you can see impact, all the impact points here are clearly above, or most of them are clearly above traumatic axonal injury and subdural injury thresholds. Down here in the lower corner is the shaking. And so it is significantly lower in her model. The problem, as I see it, is that everybody's been focused on trying to achieve this magical threshold that was derived or derived and applied to human brains based on these Generelli and Tebow and Omaya experiments in monkeys. And I think that rather than try and get to this injury threshold by modeling, we need to take a step back and understand the differences between an adult monkey and a human baby, of which there are many. So, and there's never been a good model for shaking a human infant. So the question we should be asking is not, can we accurately measure forces during shaking? I think that's a qualified yes. But are injury thresholds derived from adult monkeys undergoing single accelerational events? These are not repeated to and fro movements. These are single accelerational events of 5 to 30 milliseconds duration, even remotely applicable to infant brains, the brains of infants undergoing repetitive shaking. And the answer to that is who knows. Susan Margulies and Brittany Coates, I think both of them have commented in a paper that we don't have any models and in terms of knowing the thresholds for brain injury in infants. And so that they've made the statement in the biomechanical literature that we really can't make that statement because we simply don't have an adequate model for infants. We do know a couple of pieces of information. We know that 3 to 5 day old piglets, and piglets are one of those models that people have used to try and approximate human infant injuries and head injuries. We know that 3 to 5 day old piglets, so pig babies, have lower thresholds than do adult mini pigs with similar brain size to single non-impact rotation. We also know that repetitive injuries, twice within 15 minutes, so a piglet that undergoes an injury twice within 15 minutes has a 50% lower injury threshold than one who has just undergone a single injury. And so this suggests that repetitive injuries are important, and that repetitive injuries may lower seizure or lower injury thresholds. And no lower threshold was established in this study. And of course, we've not yet studied this for repetitive injuries that are occurring within seconds. We do know that repetitive injuries are fairly common in abusive head trauma. We know that by Carol Jenny's work, that about 40% of infant victims of abusive head trauma have evidence of prior injury. And the clinical correlate to this, I think, is the fatal second head injury, right? The athlete who goes out to a American football game, gets injured, gets a head injury, a concussion, goes to the sideline, goes out and gets repeatedly injured before they fully recovered from their first injury, even days later, and then suddenly collapses with massive brain swelling. And so I think that certainly supports this whole second impact or second injury model that we see perhaps in abusive head trauma. In terms of oscillatory loading or repetitive, again, both adult pig and piglet brains are increasingly susceptible to oscillatory loading at lower frequencies down to 20 hertz, and 15 seconds of shaking at 15 hertz in 8-day mouse pups, which is the mouse brains in these 8-day-old mouse pups are somewhat similar to infants, produces brain injury and retinal hemorrhages. And then Finney and their group have published a number of papers several years ago on the effects of shaking in lambs. And they took 7 to 10 day old lambs, grasped them under their axillae, and manually shook them for 30 seconds. They repeated that 10 times in 30 minutes. And then they sacrificed and examined them after 6 hours. In this particular study, they've had other studies as well. And they showed widespread labeling of neurons with beta APP, suggesting injury to those neurons or some metabolic change. They noticed, and I'm going to return to this concept of axonal injury, which was greatest at the cervicomedullary junction and the upper cervical spinal cord. 2 lambs had subdural hemorrhages, 2 had retinal hemorrhages, and 3 animals died after shaking. And they had axonal injury, again, most severe at the cervicomedullary junction and retinal damage. So we do have a model in lambs, at least, that wherein manual shaking can result in some sort of brain and upper cervical spinal cord injury with retinal hemorrhages. So if we want to compare, we talk about injuries in babies, but we need to compare them with what we know about adults, because we want to know are the monkey data even remotely comparable to humans at first, and then are the monkey data and adult human data comparable to babies? And again, in defense of this, or in explanation of this, there are multiple differences between infants and adults. Infants have a larger extraaxial cerebrospinal fluid spaces, and they have a relative lack of arachnoid or pachyonian granulation. We're going to speak about that in greater detail in just a second. But this is a child who has a benign expansion of the subarachnoid spaces, or benign extraaxial collections of infancy, where there's greater than 5 millimeters CSF in the subarachnoid space. And you see these vessels crossing over the subarachnoid space. And we'll talk about near the end of the talk, or in the latter third of the talk, that these children actually are at risk for subdural hemorrhages compared with normal infants. The parasagittal meninges, as you know, the superior sagittal sinus is flanked by the parasagittal meninges, within which are these venous lakes. And all of us who are neurosurgeons know that the closer you get to the superior sagittal sinus, the more likely you are to enter into one of these lakes and have a lot of venous dural bleeding. And so there are these parasagittal venous lakes are flanked by these bridging veins that go into the superior sagittal sinus. But I point you to these venous lacunae within the dura of the parasagittal venous lakes. This is a color casting here. And you can see the Pacchionian granulations. I'm sorry, these are overlapping. But the Pacchionian granulations here have been torn from their venous, from their moorings within the venous lacunae. This, I think, is important and not very well understood and overlooked aspect that might be important in subdural hemorrhages in these infants. This is just a cast of these superior sagittal sinus with these venous lacunae, and then, of course, the bridging veins, which lie deep to the venous lacunae. So the lacunae are within the dura, and the lacunae is where the arachnoid granulations insert. And we know that the arachnoid granulations insert into these areas of not only the superior sagittal sinus, where they drain the CSF into the sinus, but they also attach to these parasagittal venous lacunae. And the arachnoid granulations are almost completely absent in infants. Infants have arachnoidvilli, and I'll show you a picture of this in just a second. But arachnoid or Pacchionian granulations only become more numerous over the first 7 to 8 months, or begin to become more numerous. And by 2 years, the granulations are very similar histologically to adults. And again, these invaginate into both the dural sinus and the lateral lacunae, dural lacunae, and they're associated with these parasagittal dural channels and trabecular meshwork. And the arachnoid is adherent at these sites. Actually, I'll talk about that in a second. So this is a scanning electron micrograph showing these typical arachnoid granulations. And here is a cartoon of them. And I liken these to tennis rackets. They have a large head that's within the superior sagittal sinus or the lacunae, and they have a neck, a narrower neck, and then they, of course, ultimately attach to the subarachnoid space. And this is a depiction of this showing these caps within the dura here. There's the subarachnoid space, and it allows the CSF then to traverse into the blood. Infants, as I said, don't have these tennis racket arachnoid granulations. They instead have arachnoid villi. And you can see here in adults, this is from Keith Aronik's paper, and you can see the little cauliflower-like arachnoid granulations that have been pulled out of their moorings here. They're holes in this trabecular meshwork here, where the arachnoid granulations have been pulled out. Now, of course, if you pull out the arachnoid granulations, you're leaving a hole in that trabecular meshwork through which there certainly can be blood that comes from the dura and the venous lakes. In infants, they have these arachnoid villi, which I liken to a finger. So unlike the tennis racket head on the top of the arachnoid granulation, the infants just have a finger, and you can imagine, and Keith Aronik has shown, that it's much easier to strip an arachnoid villus out of its mooring in the trabecular meshwork of the dura than it is an arachnoid granulation with that big tennis racket head on it. And again, in this paper by Fox and Aronik, they demonstrated this, and they said that the arachnoid was much more readily stripped in an infant compared with an older child or an adult for that reason. So one of the first points of maybe controversy or innovative thought is what I call it perhaps the tale of two subdurals. In the patients who come in and get operated on, right, the ones that we operate on as neurosurgeons, what I would call surgical subdural hematomas, they're mostly convexity. They're much more commonly seen in non-abusive head trauma or accidental head injuries. They can be seen after short falls on rare occasion, and they're usually focal when they do so. There are no or minimal retinal hemorrhages. Hypoxic ischemic injury is variable, but often focal, underlying the subdural from compression of the underlying brain. And these patients' mental status is dependent on the amount of blood in the subdural space, right? The more blood, the more compression, the more brain shift, the more likely you are to be in a coma. Lucid intervals are more frequent in these large subdurals where they're gradually expanding, and so you don't have an immediate loss of consciousness necessarily, but you have a progression of consciousness as the clot enlarges. And the bleeding source when we operate on these is usually a torn bridging vein, and that's given rise to this whole concept that subdurals all arise from torn bridging veins. And of course, occasionally we've actually even seen, I'm sure some on this conference call have seen arterial bleeding as well. But the types of subdurals we see in abusive head trauma are small. We would call them skim subdurals, right? They are very thin. They are not compressing the underlying brain. They are not causing shift of the brain. They're primarily interhemispheric and tentorial in location. They're very frequent in abusive head trauma, and they're commonly associated with retinal hemorrhages. Hypoxic ischemic encephalopathy is often global and way out of proportion to the size of the subdural. And they have a high mortality, 25% or so, despite having very small and non-compressive subdural hemorrhages. And these children, we'll talk about timing, there's really no lucid interval. That is, they're either awake or they're comatose for the most part. And the question then becomes, what is the bleeding source? And so, are they smaller bridging veins? We know that we can tear smaller veins that cause less bleeding. We can partially pull on a vein and cause a tear in the sidewall that causes a small amount of bleeding and then seals up with platelet plugs and so on. We're going to talk about the falcine and tentorial intradural venous plexus in just a second. But I would propose that these skim subdural hemorrhages are the result of the arachnoid and therefore the arachnoidvilli being stripped from their moorings in the dural trabecular meshwork. And that causes a little bit of subdural blood to leak from their mooring sites after they're pulled out. Just to show you that in terms of comparing babies and adults, there are multiple venous lakes within the falx and the tentorium, and particularly in the posterior falx. In infants, they have a very rich intradural venous plexus that diminishes with age, and so that may also be a source of subdural bleeding in the interhemispheric fissure. Of course, we know also that babies have larger heads compared with their bodies or necks. They have weaker neck muscles, increased water content, relatively unmyelinated axons, right, in infants, with absent nodes of Ranvier. And we know that when you have axonal injury in myelinated axons myelinated axons, the injury primarily occurs at the node of Ranvier, the axonal injury. And so if you don't have a node of Ranvier, the question then becomes, where does the injury occur? And then what I would propose, or what others have proposed, I should say, is that there are numerous quantitative and qualitative developmentally regulated processes that differentiate the infant brain from the brain of an older child or an adult. What do I mean by that? There are, my other interest is in embryology, and as part of that, there is a well-known phenomenon within neural development of this critical time period during which you can have during which the brain relies on external input for its development. And so when we compare babies to adults, there are differences in the critical time periods. Of course, adults don't have a critical time period, whereas infants or embryologically, there are critical time periods. And I'm just going to give you a couple of examples. One is the quantitative differences. And as an example of this, I thought about the concept of cranial radiation in an infant. We know that if we radiate an adult, whole brain radiation, we get some cognitive defects, but not much. But we all also know, we as pediatric practitioners know, you can't do that to a baby. You will literally melt their brain if you have a cranial radiation to the developing brain. And we know that cranial radiation induces this age-dependent decline in cognitive performance. And that's very predictable if you know the age of the baby or the age of the child and the radiation dose. And that's just depicted here, adapted from this paper by Silber. If you know the age of the infant and you know the amount of radiation, you can predict what their IQ drop will be. And it's greater, it's very quantitative. The greater the amount of radiation, the larger the drop. But there are also some qualitative differences that occur. And the best example of this, I think, is the concept of eye patching for strabismus. We know that in an adult, if you patch an eye for 6 weeks, or an older child, you patch an eye for 6 weeks, you really get no effect on their vision. And so you would predict, based on that knowledge, that you could do that in a young baby and have the same result. But in fact, as we know, you get a pronounced visual loss. And the reason for that is because the cortex, during this critical time period, is developmentally regulated in terms of the synaptic plasticity. And if you don't have binocular input to the cells of the occipital cortex in area 17, during this critical time period, your brain simply eliminates the input from the patched eye. And that's why we don't patch the eyes of children for a long period of time when they're under about 7 years of age or so. So this is another example in which something that you would predict based on work done in adults or older children does not apply at all to younger infants or younger children. And the group primarily at Pittsburgh have enumerated a number of biochemical responses to infant abusive head injury, comparing them to children with accidental head injury in terms of metabolites that you can measure in the cerebrospinal fluid and even in the blood after injury. And just to summarize, the secondary metabolic response in infants, in these young infant victims of abusive head trauma, is fundamentally different, and is different in the amount of excitotoxic neurotransmitters that are released, ischemia, inflammatory markers, oxidative stress and free radical change or free radical damage, and then of course apoptosis, which is, or programmed cell death, which is very important in the developing brain. And the thresholds for initiating these metabolic cascades have not yet been established. And this is just a table, kind of busy, but basically shows the differences between all of these entities which have been measured in infant victims of abusive head trauma versus victims of accidental injury. And I should, with clarity, say that because abusive head trauma is in infants, 90% of them or 85% of them are occurring in infants less than 12 months of age, and accidental injuries are very hard to come by, with severe brain injury are very hard to come by in this young group. We are also comparing older versus younger infants. So there's a confounding variable there. But for example, glutamate, which is a neurotoxin at high doses, is 7 times higher in infant victims of abusive head trauma compared with older children with severe accidental head injury. And these blue markers are just neuronal and myelin markers of damage, and they're all increased in infant victims of abusive head trauma compared with accidental victims. So a number of changes that are different between babies and older children or adults. And finally, I would say that there's a perpetrator confession literature that I think certainly speaks strongly to shaking as a mechanism of injury. There There are many perpetrators who have described shaking as a common mechanism of injury. In fact, it's almost always that they describe shaking either with or without impact in their descriptions of what they did when they confess. There's an identical pattern of injuries. It's both severity and the pattern of injuries are the same whether or not there's a confession. So if you take the confession cases, the pattern and the type of injuries, the severity of the injuries, very similar to those where there's no confession. The presentation, the radiography, the spectrum and the pattern of injuries and the outcomes are very similar, regardless of whether the perpetrator admits to shaking, impact, or both. And I'll show you one example from Starling's paper. And this pattern of injuries is rarely seen following even severe and violent injury, accidental injuries with obvious impact, right? We've all witnessed that. We don't see that pattern of injuries. And this is from Starling's paper. And I want to point out to you that if they should divided them, and these are all perpetrator confessed cases, those that described impact only, shaking only, or both. And what I want to show you is a couple of things. One is that in those described impact or shaking plus impact, only a small number of them actually had evidence, or percentage of them had evidence of impact. So the first principle here is that you can have impact injury without evidence of impact injury. And that's important. The second is that, and you can see here that shaking only, there are significantly less evidence of impact, skull fracture and scalp swelling, the features that they used. But notice subdural and retinal hemorrhages are pretty much the same across the board, no matter what mechanism of injury was described. And so I think this lends strong support for the whole concept that shaking alone can cause subdural and retinal hemorrhages. This is from Vicham's paper from France. This is a paper that's been widely cited. This is abusive head trauma, witnessed abusive head trauma confessed abusive head trauma versus witnessed accidental traumatic brain injury. This is a prospective study of 45 confessed abusive head trauma, 39 publicly witnessed accidental injuries. And in France, there's no plea bargaining, so that this was the closest we're going to get, I think, to the truth in terms of confessed abusive head trauma. And in that group with abusive head trauma, there were more frequent seizures. There more frequently had elevated intracranial pressure and coma. Subdural and mixed subdural and cerebral ischemia were more frequent on imaging studies. Retinal hemorrhages were much more frequent, 85 versus 15%. Mortality was much greater, 22 versus 5%. And extracranial fractures, not skull fractures, were more frequent among that group. Interestingly, though, scalp swelling and skull fractures were less frequent among the group compared with the accidental head injury group, and radiographic evidence of impact is less frequent among that group. So despite having much more serious injuries in this group of confessed abusive head trauma cases, there was less evidence of impact, less frequent evidence of impact. And this is just from a table from their, and I'll be happy to share these slides with anybody who's on the call as well, so you can see it. So I think the Lamb model, the confessions, really suggest that if shaking alone can't achieve injury thresholds, if the monkey studies are true that shaking alone can't achieve injury thresholds, then we can't explain the Lamb model. We can't explain some of the other models that have come about. And most importantly, all perpetrators need to be consistently and universally lying about the same thing, which just, it makes no sense. It just defies logic. So let's just switch gears here and talk about the components of abusive head trauma. We all know that it's a combination of intracranial hemorrhage, mostly subdurals, more so than subarachnoid, more so than intracerebral, and least common extradural hematomas, which statistically are more common, extradural hematomas, more common in accidental head injuries. But subdurals are highly statistically significantly more common in abusive head trauma. And they're most commonly interhemispheric and tentorial in some studies. They're associated with some sort of brain injury, which is most commonly posterior, temporal occipital, and retinal hemorrhages, along in some cases with rib and long bone fractures or indicia of extracranial injury. And then I'm going to focus here on ligamentous neck and or spinal cord injuries, because we've talked about the differences between adults and children with respect to the arachnoidvilli and why subdurals might be more common. And these skim subdurals might be more commonly occurring in abusive head trauma. With respect to brain injury, I'm going to focus on ligamentous neck and or spinal cord injuries. And this has become much more well described more recently. So this is just before I do that, this is just a typical scan. You can see the hypodensities here, a mixture of of hypodense and hyperdense subdural, particularly along the posterior interhemispheric fissure here, but also along the convexity. Here's another one with a lot of posterior hypodensities on the CT scan and interhemispheric and to some extent convexity subdural hemorrhage. And this is several weeks later. The brain is literally melted away, what we refer to as walnut brain. It's just a little tiny nubbin of brain within a sea of mixture of subdural and subarachnoid fluid. These are the diffusion and ADC imaging sequences on MRI. I point this out because these are very frequent. And as you know, these particular MRI sequences have been used primarily for stroke to look for acute ischemic brain injury. And generally brain injury, ischemia that's occurred within the last 5 to 7 days or so. And these turns out, are fairly common accompaniments in abusive head trauma. There's an ischemic component. And then the most severe is this reversal sign, or the white cerebellum. You can see the cerebellum much more dense than the supratentorial compartment. There's another reversal sign wherein the basal ganglia and thalamus are whiter, more dense than the surrounding cortex and white matter. So there's kind of two different definitions of reversal sign. And these are more chronic. You can see, I'm sorry, this is MRIs, which are very nice to show the various intensities of the subdural collections here. You can see them on various imaging sequences. And we'll talk about timing in just a minute, which turns out to be much more problematic than we once thought. And then here's the more chronic subdural with the somewhat expanded subarachnoid space. You would expect this to be much more compressed. Retinal hemorrhages occur in somewhere between 50 and 100% of cases. If you average all the studies, it's about 80%. They may be predominantly or even strictly unilateral in up to 50% of cases. They're usually, but not always, associated with intracranial hemorrhage. Maybe 3 to 5% of them may occur without any visible intracranial injury. And about 3 to 5% of them can occur after accidental trauma. And in almost all of those, the mechanism of injury is obvious, and hemorrhages are mostly few and limited to the posterior pole. And I'm going to just talk just for a bit about retinal hemorrhages, because as Alex Levin, who is one of the predominant authors of studies in retinal hemorrhages, has said, to speak about retinal hemorrhages as if they're a sort of just a one entity without describing the different kinds and the severity of the hemorrhages is like saying that a rose is just a flower. Vitreous, so there are different kinds of hemorrhage. There's vitreous hemorrhage. There's pre-retinal or sublimiting membrane hemorrhage, which is in front of the retina. These are the so-called subhyaloid hemorrhages that we in neurosurgery hear when we talk about those that appear, for example, in adults with aneurysmal subarachnoid hemorrhage. And the retinal vessels are obscured in these pre-retinal hemorrhages. There can be intraretinal hemorrhages, that is within the retina. They give rise to the dot, blot, or flame style hemorrhages. And then subretinal hemorrhages that are beneath the retina. The blood vessels are visible on top of the hemorrhages. And then most importantly is retinoschisis, which is not retinal detachment. It's a separation within the retinal layers itself, sometimes associated with perimacular folds, where there's been this bleb the retina has been ripped apart, and there's blood in this schisis cavity you can see here. And then the top part sort of collapses down and folds on itself, and that causes this perimacular folds. And that's present in about a quarter of cases, is these retinoschisis. And it's important because the number, the location, and the type of retinal hemorrhages are all important in terms of their specificity for abusive head trauma. Hemorrhages that are in multiple retinal layers, preretinal, intraretinal, subretinal, are more commonly a sequela of abusive head trauma. Hemorrhages that extended out to the edge of the retina. Think of the retina as a bowl. These would be at the rim of the bowl in an area where you can't see with a direct ophthalmoscopy. And that's the ora serrata. And then traumatic retinoschisis, which is the most specific for abusive head trauma. There are very few other cases other than abusive head trauma where you see traumatic retinoschisis. Most of those, there have been a few cases, severe crush injuries, child that pulled over a television on top of their head, a sibling that fell over and landed with their butt directly on an infant's head. And those children have massive eggshell skull fractures. So it's very obvious that there was a crush injury to the head. And then in severe motor vehicle crashes, there have been a couple of cases. So retinoschisis is really quite specific for abusive head trauma. And then these neck injuries, which I'm going to focus on. There are, and this started with actually the work of Mark Hadley, believe it or not, a neurosurgeon who was then a resident at Barrow in 1989, published on this about postmortem fatal cases with injuries to the cervical medullary junction and the upper cervical spinal cord. And subsequently, there have been a number of other studies on postmortem fatal cases that have demonstrated this. We looked at, Arv Chowdhury and I looked at living children via MRIs, and started to get MRIs of the entire spine in these patients. And what we found out, we used STIR sequences, which are the much more specific for ligamentous injury, and we'll see pictures of it in a second. And we started to look at this, and we compared 3 cohorts. We had an abusive head trauma cohort, we had an accidentally injured cohort with clinical suspicion of neck injury. So these were select patients who were being imaged with MRI because there was a suspicion of cervical spinal cord injury, and then a non-traumatic cohort who was getting imaged for reasons other than trauma. We found that almost 80% of the abusive head trauma cohort had evidence of ligamentous injury in the upper cervical spinal cord from occiput to C. Well, we had it all the way down, but it was focused primarily in the upper cervical cord. In the accidentally injured cohort with clinical suspicion of spinal cord injury, it was 43%, and only one case, a child with sepsis and multiple prolonged seizures, had any kind of cervical findings on MRI, and it was a little bit of edema in the soft tissues. So here's a normal MRI, and this is obviously a drawing here, but I draw your attention to the nuchal ligament, which attaches the spinous processes of the cervical and upper thoracic vertebrae to the skull. And on T1, T2, and STIR-weighted images, you can see on T1 there's a normal, this is the normal circumstance. There's some marbling from the fat. You can see some hyperintensity, but on STIR images, it should be completely dark. And here are examples from our paper showing this nuchal ligament injury on STIR. These are all now STIR imaging sequences. And you can see on every one of them, there's this hyperintensity involving the nuchal ligament. And we also found less commonly injury to the other ligaments of the neck, the atlantoaxial ligament and so on. And we found that there were significant correlations in this group between cervical ligamentous injury and brain ischemic anoxic injury. We combine the abusive head trauma and trauma cohorts. Highly statistically significant. Now, it may be, and obviously the conclusion is that more serious injuries cause more serious brain injuries and cervical cord injuries. But it's interesting that it's ischemic anoxic injury So the proposal is that these infants have an upper cervical cord injury, which we didn't see by an MRI, interestingly, but which was found in the autopsy series, not infrequently, cord injury. So I think this may be a neuropraxic spinal cord injury that results in, because it's upper cervical, it results in hypotony or apnea, which we know is very common in abusive head trauma. We know that infants have disordered breathing at the time of their injuries. It's a very well-described phenomenon. And that leads to the brain injury, which is primarily ischemic anoxic. So again, this new paradigm, the primary traumatic injury is at the cervicomedullary junction or the upper cervical cord. It leads to disordered breathing and secondary ischemic brain injury, perhaps confounded by also these metabolic changes like glutamate that's released because of that. And this is supported by when I was in Japan, I was giving a talk on abusive head trauma, and I asked, has anybody ever seen a out of control seizures for 24, 48, 72 hours in children who have accidental head injuries? And that's really, really rare. But in children that were victims of abusive head trauma, with serious head injury, it's very common to have multiple seizures that are difficult to control, that often require 2 anticonvulsant medications to try and control those seizures. And then after about 48 hours, they go away. They just stop, and you can wean off the second anticonvulsant and so on, and they don't seem to recur. And I asked, has anybody ever seen that with accidental head injury? And one of the neurosurgeons raised their hand and said, no, I've not, but I've seen it in the group with near drowning and hypoxic ischemic encephalopathy, which we all know. And so I think that really provides support for this concept that the primary brain injury in these children with abusive head trauma is ischemic anoxic injury. And we know from McGuire's article, which is a very nice article in the Archives of Diseases of Childhood, that apnea has a 93% positive predictive value for abusive head trauma with an odds ratio of 17.6. So I think all of that speaks to that. I'm going to spend, I'm sorry, I don't have much time here, but I'm going to speak to the mimics. You know, there are a number of things that we need to consider, and then there's abusive head trauma, and clearly there's an area of overlap. And the question is, how much of an overlap is there? And that's debated. Let's start with short falls, which is the most common defense or thing that we need to consider. And there are multiple comparative studies that have looked at abusive and accidental head injuries, including in the accidental injuries, many children with falls. And you can see that they're listed here. And if you take those all as a group, serious or life-threatening injuries other than epidural hematomas are extremely uncommon in falls of less than 4 feet or a little over 1 meter. Epidurals, again, are more common following accidental injuries. The odds of death in the aggregate out of 26 studies of 1,900 patients, the odds of death from a fall are 23. And 18 of the 23 were from falls of greater than 3 stories, which I think we can all agree potentially is fatal. So the risk of fatality from a fall of less than 3 stories from these 26 studies is 5 out of 1,900, or 0.25%. Most of the injuries include skull fractures, epidural hemorrhage, subarachnoid hemorrhage, and small focal contusions. Subdural hemorrhages do occur, but they usually are focal, small, and underlie the point of injury with the scalp swelling. This study by Vinchan, another great study I talked about before, again showing quite a lot of differences, and I've already covered this, so I won't do it any further. If we look at children with witnessed short falls, and most of these are in hospital, so these are witnessed and clearly not abusive injuries. There are 800 of them reported among several studies, and I tallied them up. Many of them are falling out of a bed, out of a chair, out of a crib, out of parents' arms onto the floor when they fall asleep trying to feed them. And out of those 802 children, now most of them did not get any imaging studies because they were fine. They were normal afterward clinically. But of the ones who who were imaged, only eight had skull fractures. And there were no neurological abnormalities or deaths in this group of over 800 children with witnessed shortfalls. And then finally, Chadwick's study on childcare deaths. These are childcare centers where there's line of sight visibility. There's multiple providers to try and make sure that people aren't isolated in a room alone with the child. And so they really strive to avoid cases where there wouldn't be an unwitnessed injury. There were only 2 fall-related deaths among more than 6 million children aged 0 to 5. And so they said that the injury from a child fall-related death in a daycare center is less than 1 per million per year. And they noted there's no peer-reviewed report of a fall-related death in licensed daycare facility. And when we talk about mechanism of death, it's different. And I think we as neurosurgeons understand this better than anybody. When we see a child with a large subdural hematoma and who dies from uncal herniation, we're not surprised, right? That's expected. But the mechanism of injury of death, the mechanism of death from a short fall is understandable when a child dies from a short fall, is understandable from that standpoint. In this study by Hall, which has been criticized on a number of other basis, but this was 44 child deaths from falls. Okay, so we're talking about children who died after falls. 18 suffered legitimate shortfalls of less than 3 feet. All of them died from lethal head injuries. 100% had skull fractures. And I point to this: 3/4 of them had surgical mass lesions, large epidural or extraaxial hemorrhages. So we're not surprised that those children would die. And I had a child who fell off a cot onto concrete, had a skull fracture over the middle meningeal artery, and came in with a huge epidural hematoma. Fortunately survived, but that's an explainable. If that child had died, that would be an explainable death. And so the type of injuries that we see in the children who die from falls are expected. There are some increased risk situations. Children who are dropped from parents' arms are at slightly higher risk of more severe injuries. Falls downstairs because the children are turning. They're and again, an accelerational mechanism. Walker injuries downstairs may be more severe. And there are occasional children who've had occipital impacts. This was reported by the Helfer Society for Child Abuse Pediatrics. And this is a very select series, but 8 cases that they collected. 6 out of the 8 had subdurals, 2 of them surgical. 2 out of the 5 had infarctions on MRI, retinal hemorrhages in 7 out of the 8, but no retinoschisis, and 1 death. All of them had returned to baseline by the time of discharge. So there are some increased circumstances. Birth trauma, just real quickly, the incidence of intracranial hemorrhage following a normal birth is actually quite variable, but can be quite high. And this one by Rourke, it's up to 46%. Now, these are MRIs done on normal infants who were normal births and who were imaged, who had no problems and were imaged just to see if there was evidence of subdural hemorrhage. All of them are gone within 3 months, 94% within 1 month, and no clinical complications in any of them. Retinal hemorrhages are also more common after birth, 40%. But again, most of these resolve within 4 postnatal weeks, and all are gone, according to Levin, by 6 weeks postnatal. So if you have an abusive head trauma suspect within 6 weeks, I guess you could entertain the thought, but almost all abusive head trauma cases are more than 6 weeks old. Benign extraaxial collections of infancy or benign expansion of the subarachnoid spaces. We all know this. Macrocephaly, positive family history in 40%, about 60% are males. Occipital plagiocephaly is fairly common in this group, and they have a classic head growth curve. They gradually cross over the 95th percentile, and then by about 12 to 18 months or so, they taper off and then begin to parallel the curve or come back down toward it. And this is a depiction showing the widened subarachnoid space. And in this depiction here, the bridging veins are thought perhaps to be, and again, I think also the arachnoidvilli may be involved to a greater degree, but in this case, the bridging veins are better, traverse that space. Here's a CT scan showing it. Here's an MRI showing the increased extraaxial CSF. And notice these vessels that are crossing. Interestingly, Bob Harbach, my chair, noted he saw this and he said, we see adults all the time with atrophy of the brain. We don't see these vessels crossing the subarachnoid space in the adults with atrophy, which is kind of interesting observation. Here's the one we showed before. And it's been known or suspected that there are a few children who have benign extraaxial collections of infancy who can tear these bridging veins and get subdurals. Now, these are all essentially all asymptomatic subdural hemorrhages. And there are two nice papers, one by McKeague and Greiner, both of them in 2013, that actually put a number to this. It's about 2% of cases that have associated subdurals complicating their subarachnoid hemorrhage, subarachnoid collections. And so you see this subdural above the subarachnoid layer, associated with minor or no reported trauma, asymptomatic otherwise. I had one child who had an isolated seizure, presumably at the time of the hemorrhage. Only one reported case with associated retinal hemorrhages from Joe Pyatt. That's the kind of controversial article, actually. And but it may be difficult to exclude chronic abuse. And here's a case, nice example of occipital plagiocephaly, widened extraaxial spaces. And then you see this subdural overlying the enlarged subarachnoid space. Here is one on MRI with a very large subarachnoid space and then overlying. But you can imagine if you have a chronic abuse with atrophy of the brain, this might look very similar. And then other rare mimics, genetic metabolic conditions, we need to consider glutaric aciduria. Menkes kinky hair disease has cases with subdurals, osteogenesis imperfecta with multiple fractures, Ehlers-Danlos. I had a patient with Ehlers-Danlos who had subdurals and actually had a family member die of an aortic aneurysm, ruptured aortic aneurysm, while the baby was in the hospital. Coagulopathy, particularly consider delayed hemorrhagic disease of the newborn from vitamin K not being administered. Aneurysm and vascular malformations, the pattern of hemorrhage is clearly different. And infection, obviously a consideration, but usually readily excluded. And I'm going to stop here and not talk about timing because I'm already about 5 minutes over. I'm happy to take questions from folks.
Dr. Dias, we are happy. I'm sure the audience will be happy for you to go through the timing. I think that will be very important to us.
Okay. All right. Happy to do that. I'm sorry I went longer.
That's okay.
So the timing really gives us obviously an idea of who might or who might not have been a perpetrator. And evidence of prior abuse changes the legal charges against the perpetrator, right? And so timing, accurately measuring the timing is really quite critical. If we look at just look at the clinical outcomes, serious or fatal injuries almost always result in significant and sustained change in the level of consciousness from the moment of injury. This paper by Willman, an older paper, but this is widely quoted, of 95 children with accidental injuries. These are not abuse, but accidental injuries who died. All but one were comatose from the moment of injury, and the single exception was a child with an expanding epidural hematoma. Okay, so this is widely cited as evidence that there is no such thing as a lucid interval. Johnson and Bowl, in their study in 1995, 28 infants with abusive head trauma. I point out a couple of things that 57% with apnea or disordered breathing, and they concluded that apnea or breathing difficulties are an accurate marker clinically for the timing of injury. Starling, and again, in her case, in her study of 151 cases with 37 confessions, all but one of them of the confessions, the perpetrator described that they were with the child at the time that symptoms began. And so they concluded that symptoms occur soon after the abuse and do not evolve over a period of hours to days. Gillies and Nelson, another paper, 14 infants with unconsciousness, apnea, respiratory difficulties, and seizures. None had a lucid interval. Gilliland, 76 infants with abusive head trauma, said in all cases in which the children were seen by an independent observer after the injury, they were described as not normal. And of course, these children who are described as having lucid intervals are often brought into the hospital by the caregiver because they're not normal. And it's important to understand that these, lucid interval, when we talk about a lucid interval, a lot of times people use that term very loosely because the children are not acting normally, but they're still awake. But any normal person who looked at them would say, yeah, that's not a normal child. And there's really no well-documented, or I should say very, very, very few cases of lucid interval in which the child was acting completely normally before they deteriorated. In all reported cases, children were brought to medical attention again before deterioration due to symptoms or initial loss of consciousness. The problem is that the less severely injured children who don't die or who don't suffer coma, it's problematic, right? We don't know when that we're much less what's the word I'm looking for? Certain as to when the injury might have occurred. Can a child have a single seizure and then recover after an injury that occurred hours or days before? Absolutely. So a single seizure can't time an injury. Could modest clinical deterioration occur in a delayed fashion? Yes, it can. So those are much more problematic cases. We looked at did 2 studies on timing of abusive head trauma based on radiography. And the problem was that this came out of a discussion I had with a neuroradiologist, peds neuroradiologist, who said that hypodensities only appear after 24 to 72 hours after an injury. And I said, where did you get that information? And he said, well, that's just what it says in our literature. I went and looked it up, and it's actually extrapolated from the ischemic anoxic, near drowning literature, which of course is crazy, right? You're comparing apples to oranges. So we decided we would evaluate all the children with abusive head trauma. We would look at all of their imaging studies performed at all periods of time. And we asked, when do things first appear and how do they evolve over time? It's 2 simple questions. And, unfortunately, these are limited because the children's imaging studies are done by clinical indications. And so they're not being imaged every day. So we have gaps in the imaging. The first study was 33 infants at Buffalo. And then when I got to and these were all CTs, when I got to Penn State, I analyzed 115, a much larger group of children, and also many of those had MRI scans. But I asked the same 2 questions. And these are sort of the composite of the 2 studies. The time to the first hypodense component of let me start down here, parenchymal hypodensities. The earliest we found was 1 hour after the report of the injury. Commonly, they were within 1 to 5 hours of the injury. The longest we had was 27 days. So most of the patients are going to appear within the first, these hypodensities will be apparent. Even global black brain or dark brain can appear very early, within a few hours, not days, as was previously assumed. If we look at subdurals and try and find if they on a CT scan or MRI scan, can we date a subdural? We looked at in patients who had acute uniformly hyperdense subdurals and said, when can we see the first hypodense component of a subdural? The earliest was on the first day, the commonly within a week or so, and the longest was a little over 2 weeks. We asked, when does the last hyperdense component disappear? The earliest was 2 weeks, usually 20 to 40 days, and again, the longest 160 days. So really quite a large gap or range. And then if you look on MRI and look at what we would refer to as early subacute pattern and late subacute pattern based on the intracerebral hemorrhage literature, the earliest was 1 day, commonly within a few days, but longest 5 for early subacute pattern and 30 days for late subacute. And so what we concluded was that it's very difficult to accurately time. Now, the parenchymal hypodensity, I'm very comfortable that you can see it very early on, but trying to time a subdural based on the imaging studies is very problematic. And also this question of this dogma that we've had that a combination of hyper and hypodense subdurals is prima facie evidence of multiple abuse episodes. That's gone by the wayside. And that's largely, again, the work of Vinchan. There's a number of other papers that suggest it, but Vinchan looked at, in this paper, 18 infants, so all infants with subdurals due to traffic accidents, okay? So these aren't abuse patients. 3 of the 18 had mixed density collections on their initial CTs. Now we know that from a number of studies that mixed density subdurals actually are much more common in children victims of abusive head trauma than accidental injuries. But Vinchan's paper shows us that you can, unless these children were abused and then got into a motor vehicle crash, Vinchan's paper suggests to us that we can have mixtures of chronic or that look like acute on chronic subdural. Why is that? Well, I think if we go back to this paper by Zoros and Keith Aronik again, these were 5 infants who underwent evacuation of mixed or low density subdural following non-accidental injury. And what they did was they injected a radioisotope via LP immediately following the insertion of their subdural drain. And they detected the radioisotope within the subdural fluid within 3 to 24 hours. And so what they suggested was that there was a tear in the arachnoid membrane that allowed an admixture of CSF and subdural collection. And that, and also, they also suggested that the subdural may also separate out. So you have hyperdense clot, you have hypodense serum, and then mixed with CSF, which is hypodense, that can give you this admixture and a picture that looks like acute on chronic. So in conclusion, we really have a much more nuanced approach. Now, it used to be thought that if you had subdural retinal hemorrhage, that equals shaken baby syndrome. And that's really no longer adequate. It's much more complex than that. The mechanism is not as important as differentiating abuse from non-abuse. Really, I mean, I think we shouldn't be focusing as much on the mechanism. Timing is a more difficult issue than we originally thought. I think it's important to keep an open mind, to investigate, to exclude, document other potential causes. And I should say, I think that the child abuse pediatricians serve an invaluable role in working these patients up. Beware of potential mimics. I always write, don't write dumb things in the chart because they will come back to haunt you in court. Know your literature if you're going to talk authoritatively about this, because there's a lot of literature to cover. And in court especially, they will hammer you about your knowledge of the literature. So don't testify as an expert witness unless you really know the literature well and know the potential pitfalls and details about a number of things, including conspiracy theories, which we really haven't talked about. Just for further reading, this is a paper that R. Chowdhury and a number of other people wrote, a consensus statement on abusive head trauma in infants and young children, 2018, a very nice review of the sort of the global literature on abusive head trauma. And with that, I will stop and take questions.
Thank you very much, Dr. Dias. That was a fantastic lecture and a unique resource for us to look back at that. And you took us from the beginning, from the science to the clinical, and the literature references were fabulous. May I please ask Mr. Richard Edwards to comment on the lecture and then any questions for Dr. Dias. Thank you, Mr. Edwards.
Firstly, that's a great lecture. Thank you, Marcus. Excellent. And I mean, there are so many areas of controversy in this field. I don't really know where to start.
Yeah.
I think for me, I deal with a lot of these in court. I try and go to all of them with an open mind. I think in the UK, a lot of the controversy surrounds timing, and particularly where there may be two caregivers sort of around the place, but one of them's holding the baby when they collapse. And was there a lucid interval? And particularly difficult if there was a possibility the baby wasn't behaving normally. And I had an existential crisis precipitated with the Duane Big Black Brain experimental paper from a couple of years back, which was for me a very key paper in our understanding of how the hypoxischemic, hypodensity changes evolve. And for the other listeners who aren't familiar with this paper, the residents here, essentially. The experimental model started off looking at subdural hematomas, thin film, no mass effect, and hypoxic insults to the animal model. And it was only when there was an addition of invoked seizures that they developed the black brain findings. And so that's one thing. And the second thing is that we're used to seeing hypodensity in stroke, and but those hypodensities take a lot longer to evolve than the hypodensities we see in NAI, as you've said, and also in the other important paper by Paul Steinbock on the witnessed accidental injuries, where again a similar time frame of appearance. And so pulling the two together, it looks to me as though we're looking at a slightly different phenomenon than a pure ischemic insult that causes black brain. And there are two things that stem from that. Firstly, does that mean that some of them are reversible if they hit them early enough? So we've seen ADC changes can be reversed in small infants if you're really on it. Not completely, but it certainly appears that the brain volumes may be more salvageable. And the second thing, it's back to that timing. So could you have a sort of a less severe hypoxischemic insult plus a thin film subdural from an infant, and then could the baby collapse an hour later in the hands of a different caregiver, and they carry the can for that? And I think for me that's one of my big agonizing dilemmas on the basis of this new research. I'd really appreciate your comments on that thought.
Yeah, I think those are excellent comments, and we could spend a whole hour talking about just that, right? Tinahain's paper, she's been working on this for many years, and the combination of blood in the subdural space associated with seizures and a heightened presumably a heightened metabolic demand can produce hypodensities in her pig model. And so that raises the question, and I had some concerns as well when I read that, and I've heard her speak several times about which comes first, the chicken or the egg, right? Do you have a hypoxic ischemic encephalopathy leading to these uncontrolled seizures, or could you have somebody who has a subdural with seizures who have an increased metabolic demand who then gets hypodensities or areas of ischemia? And that's, I think, a legitimate area of discussion. With respect to and I had another point about the lucid interval. The children who are under about 6 months, of course, and Tinahain's talked about this as well. It's a brilliant person, but she's talked about how in older children we use the Glasgow Coma Score, and we have a pediatric Glasgow Coma Score, but she acknowledges that in infants you can really have an infant who looks okay because their eyes are open, but she notes that their face, they show no emotion, right? Then she uses this FACES scale, and these are children who are basically obtunded, but infants, and they just have if you pinch them, they don't cry, they just lie there. So she's challenged it on that basis as well in terms of the timing and the identification of a normal infant that's less than 6 months old. Fortunately, the median age for abusive head trauma is about 5 to 6 months. So most of them are going to be above that, and that isn't a problem. But identify, especially somebody who's not all that observant, identifying that the infant's normal may be problematic. They may just not be looking very, very carefully. But most of the cases, I think it's very clear that the infant was fine, eating, doing well. And then all of a sudden, this person reports that the child, the eyes roll back in the head, the child suddenly becomes unresponsive, stiffens, has disordered breathing. And I think those cases are pretty easy. Is it possible that the child's okay, and then an hour later or 2 hours later, with another caregiver, suddenly deteriorates? I think it's possible. I think a lot of times people, though, confuse, and none of us wants to make a mistake, right? None of us wants to condemn somebody to prison if there's any doubt. But the legal system requires us to have a reasonable or beyond a reasonable doubt standard. And some people conflate that with, absolute certainty, right? And I think if you're going to be testifying as an expert witness in cases in court, you have to understand that standard, and that there is going to be some degree, albeit hopefully very small, that you were wrong. And I wrote a paper with which is really an interesting paper, talking about the definition of reasonable medical certainty. And by the way, the beyond a reasonable doubt standard is for criminal cases and by the jury, not by the expert witness. The expert witness, at least in the United States, is his duty, or her duty, is to testify within a reasonable degree of medical certainty. And what that means, that reasonable degree of medical certainty, is variable. There's a really interesting study by I forget the name of the folks, but they queried judges, jury members who had not been selected for jury duty, and so they quizzed them afterward, and sociology college students on their definition of reasonable medical certainty. And in all three groups, including judges, they decided that it was somewhere around 90% certain, which means that they're willing to accept that 1 out of 10 times they're going to be wrong. Now, to me, that's far too much. I can't sleep at night with that degree of uncertainty. And so I've said in court when I've testified that that standard to me is too low, and that when I testify, I want to have in my mind that I'm not going to be wrong more than about 1 in 50 or 1 in 100 times. And so I choose 98, 99% assurance, at least an estimate, that I'm right in my testimony. Somebody then turned that around and said, Dr. Diaz was willing to be wrong 1 in 50 times. That was published.
You can't win.
So anything you say in court can and will be used against you subsequently. But yeah, those are all valid points. And I think that we need, in each individual case, as you, we need to take all of the factors into consideration and really try and come up with a conclusion that we can live with and sleep at night.
For infants and children with surgical disorders of the nervous system. These are diseases that
somebody's listening to my other
spinal cord and the peripheral nerves. And I focus on all disorders of the pediatric nervous system with a special focus.
Is this a question now, or is this somebody playing something?
Yeah, somebody's playing, I think, a previous talk of mine.
The other thing that I often hear from lawyers that I think it might be useful to mention is the concept of the subdural space and how that plays into this, because there is an erroneous view that subdural fluid moves freely around the brain and into the post fossa and down into the spinal canal, and actually you have a continuous layer of dura. You have the dural border cell layer that cleaves apart when you get the tearing of bridging veins, tearing the arachnoid, and this sort of admixture of CSF and blood going into that space. And that cleavage process is clearly going to only occur when there's a pressure that's driving it. And once those pressures equilibrate either side of the newly formed subdural collection and the subarachnoid space, then that expansion is going to stop. And I think that's quite an important concept to hold in terms of understanding isolated lumbar subdural collections, which again seem to be a very strong biomarker for abusive head trauma. Would you like to comment on that?
Yeah, Arv Chowdhury and I looked at that as well, and I have to say that's really been Arv Chowdhury driving that. But we looked at the spinal injury in children with abusive head trauma, and you're right, we found subdural blood that was always of the same intensity as the intracranial hemorrhage. And a lot of them were in the cervical subarachnoid or cervical subdural space. But about half of them, a little less than half, I think it was 57% were in the cervical, could be imaged on the cervical imaging study, but a little less than half of them had subdurals that did not extend up high enough to be seen on cervical imaging. And so we would see them in the lumbar space. And originally I thought, I talked about that and about whether do these children have a direct injury to their lumbar spine. But we quickly came to the conclusion that there's no other evidence of injury to their lumbar spine. And so we can, and by the way, all of the patients who had, as I recall, in our study, who had spinal subdurals, they had posterior fossa subdurals. And so we think that the posterior fossa subdural is what extends down into the spinal canal. But we didn't think that they had direct trauma to the lumbar spine, that this had dribbled down from above. And of course, the spinal subdural space is a little different than the cranial subdural space. So there may be some different mechanical issues going on in the spine. We do note that it falls. They seem to fall down into the lumbar spine, probably by gravity.
But going back to this dural border cell cleavage concept, it's difficult to the babies are usually supine from the get-go once they've collapsed, and there's often a relatively high volume in the lumbar spine, and certainly in our experience, our series of NAI cases, they're more often than not discontiguous and not always associated with posterior fossa bleeds. So I think thoracolumbar excursion is really the only logical sort of explanation for that we can conceive. I mean, it's what you don't have is bridging veins in the spinal subarachnoid space, so that makes it difficult. So is this shearing of the nerve roots and vessels alongside the exiting nerve roots that's causing these lumbar subdurals? We do often see.
There's another possibility. As you said, there's no bridging veins in the spine, and so it's possible that these are. It's possible that the subdural is originating in the cervical spine and then sort of dripping down as the arachnoid strips off of the dura. I'm not sure whether the spinal subdurals, and maybe you can comment about this. I don't know that anybody's looked at this being strictly in the spine, a strictly intradural collection as it is in the cranium. And by the way, for the residents who are on, what we're talking about is that we talk about subdural hemorrhage in the brain or around the brain. But technically, if you look histologically at this, as Dr. Edwards is saying, if you look at them histologically, the blood clot is actually between what's called the inner dural cell border layer, which is a strip of cells in the dura itself, and the lamellar portion of the dural membrane. So technically, it's all intradural. It's actually within the leaves of the dura, between the lamellar portion and the dural border cell layer. From a functional standpoint, I don't know that makes a huge amount of difference to us. And so we often still talk about subdural hematomas from a clinical perspective. We don't talk about intradural. We haven't changed our nomenclature to intradural hematomas. But technically, it's important to understand that. I don't know that anybody's looked at the spinal subdurals in that manner. Do you know whether there's an interdural border cell layer on the underside of a spinal subdural?
As far as I know, I mean, effectively can I share a screen a second, Naren?
Absolutely.
That might be easier to. Can you see that or not? As a I mean, can you is that so? You've got so this is what we're talking about for the residents on the meeting. So essentially, you've got the brain here, you've got the subarachnoid space here, and then you've got this dural border cell layer here. So the arachnoid and the dura are essentially a continuous layer of cells. And when we operate on these patients, what happens is we're cleaving that dural border cell layer, and then the arachnoid that we see when we open the dura beneath what we think is of as a subdural space is actually we've cleaved that by separating the dural border cell layer. So the dura splits off from the arachnoid. So you're seeing these. So when you've got this CSF ingressing and blood in these traumatic events, you've got this sort of cleavage process that drives the expansion of the subdural collection. And Mark, I think my understanding is that this dura to arachnoid continuum, if you like, is the same in the spine and all over the nervous system. I think what's different in the spine is you don't get the bridging vessels. Yeah. So, but I think in the spine, you're I mean, this is what you were talking about, isn't it? The sort of these post-mortem cases where you've got avulsed bridging veins, but it is. You can just stop sharing now, Naren, I guess. But I think conceptually, I think that for me, that says that these subdural collections can't easily spread from compartment to compartment. They have to sort of cleave their way down, and I think intuitively it seems unlikely that they do that without leaving at least some semblance of a trail of some blood products or something in the subdural space more rostral to the lumbar collections that we see. Does that make sense?
I think that's an area where we don't, again, one of many areas where we don't really an absolute idea of what happens. With respect to cranial subdurals moving or growing, I was just thinking, again, another sentinel paper by Vishang, where he looked at timing of subdurals in his paper. One of the interesting things he showed was that, because he looked at where they appeared over time. And what he showed was that they migrated posteriorly over time in his paper. So raising the question of, as you said, I've always thought, well, gee, a subdural isn't going to move, right? It's the arachnoid and the dural border cell layer. But in Vinchon's paper, blood appears in a different spot over time from where it originally appeared, or at least his studies suggest that. And I'm not quite sure how to explain that, right? If we both agree that it shouldn't migrate, I don't know how to explain his result.
I think when we're looking with some as a work in progress for us, but where we've looked at it, I think that the collections can continue to expand over time. So we do see growth in collections, but what we don't see is remote collections popping up in another compartment. I think I don't know if Jeff's so I think you can get ongoing expansion of these collections, particularly where you've got a strong driver. I think with these sort of we call them, I don't know, traumatic hygromas, but I mean the mixture of blood and CSF, and I think those can get very large, and often we need to tap them. But I think it's interesting. Naren, have any of the audience got any questions for Professor Steers? You're on mute, Naren.
It's Jeff.
Dr. Jeff Tebow, can I please get you to comment on Dr. Mark Dice's lecture and your questions, comments as well, please?
No, it's a fascinating lecture. Thanks very much indeed. It's just brilliant. It was questions really relating to some of the literature on confessions and also mimics. There's a recent paper by Edwards that was published in the journal called Child Abuse Review, which was purported to be a systematic review of all the papers related to confessions with subdurals. But what the authors did for some reason was they divided the confessions into the majority, those where there was if you like, a sudden loss of impulse and shaking, and those where the authors described as where the perpetrator was attempting to revive the child from apnea or a seizure. And then another paper has picked up on this and suggested that a lot of these cases are, if you like, a near-miss sudden infant death or what we call in pediatrics a BRUI, or apparent life-threatening episode. So child suddenly collapses, pick up, shake, put down, and the child doesn't resume consciousness. But when I then tried to look at the literature, what one might expect from near-miss sudden infant death, or even sudden infant death, or these apparently life-threatening episodes, the literature is a little bit sparse, and I guess because a lot of these infants recover well and of course don't get imaged at all. So I don't know if you've got a comment on whether medical legally this is going to be a bit of a conundrum for us as well.
Yeah, and this is another area where people have is how many of these are legitimate and how many are not. I find it interesting, though, from a medical legal standpoint, that the same people who would bring this up and say, well, this is a child whose parent was just terrified and they shook them to revive them, are the same people that in the next breath say, but it's impossible to shake a child hard enough if you're violently doing it on purpose. It's not sufficient to produce any injuries. So sort of speaking out of both sides of their mouth. Of course, it's possible that somebody could lose control and shake, and the question is whether that act, whether it's done out of terror or out of anger, is something that a normal person would consider to be reasonable behavior, even under the circumstances. So, and again, that doesn't get to intent, right? I mean, if we think that a child is shaken violently by somebody who's angry and causes these injuries, could a person who's terrified and shakes their child equally violently suffer the same injuries? I mean, I think if we say that shaking can cause, that there is a amount of force that can be imparted by shaking that results in subdurals and traumatic axonal injury, or ischemic anoxic injury, or injury to the cervicomedullary junction, we can't infer intent from that.
No.
I mean, I don't know how to answer that except to say that normal human beings generally don't do that.
Yeah.
Think of a child with a near death and violently shake them to recover.
It's just interesting that when you mentioned intent there and the nomenclature about abusive head trauma, I went into court and the barrister sort of said, "Abusive head trauma, Dr. Tebow." I said, "Yeah, that's what we call it." And he said, "Well, you're implying intent, aren't you?" I said, "Well, I guess I am." And I thought about it. And he said, "Well, Dr. Tebow, that is a matter for the court to determine." And I suppose, in a sense, he's right, and that we can't imply intent from what we see. So I do still use the term abusive head trauma. When I go into court, though, or in my reports, I say that this has been inflicted injury or abusive head trauma. However, I'm not in any way implying intent here, because that is a matter for the court to determine with all the available evidence to hand, or something like that in my report, just to overcome that slight difficulty.
The CDC, many years ago now, we had a conference that was funded and sponsored by the Centers for Disease Control and Prevention. And the book that came out, you probably have seen a little maroon book, but the title of it was Inflicted Neurotrauma, which was the name that the CDC sort of settled on as their nomenclature. Right, some people would say, well, abuse is a legal definition, and that we shouldn't be doing that on the basis of the medical evidence. But, so we can call it inflicted. I mean, I've heard people argue this back and forth. I still think that there's child abuse pediatrics, right? That's a specialty.
Yeah.
And so from a medical perspective, it is a medical diagnosis, right?
If I permitted to ask one more.
Sure.
No,
As many questions.
You're probably aware of it. I think most of the work emanates from a group in Sweden where they talk about the notion of circular reasoning. I think Vangean's paper really puts that to bed, to be honest, but it's still coming up. I'm just reviewing a paper from them at the moment, which is just like, it's crazy.
Yeah, and I woke up early this morning and was thinking, oh, I need to review all of that again because somebody will ask. For those of you who don't know, this Swedish study, the SBU, published this paper. It's supposedly the evidence base of the triad, and finding only 2 papers that they found, Vincent being one of them, and Adamsbaum, which is that same group in France, that they felt achieved any degree of medical or of evidentiary basis. They did exclude a couple of other papers that I think also could be used, like Starling's paper, for example. There's as you know, Dr. Tebow, there are numerous papers that have talked about the limitations and the bias of the SBU study. It's interesting that one of the SBU authors, I think it was the author or somebody who instigated the study. I think it was one of the authors. Son was in San Francisco and accused of abusive head trauma, and that's how the father of or the grandfather of the infant became involved in all of this, and then talked to one of the lead authors on the study, on the SBU study, and that's how this all got started. So, it's interesting, the backstory history of this began with some grandfather's crusade about their feeling that their son was innocent. But there's a number of methodological flaws in there. They used, in addition to using the triad, which nobody uses in isolation, they also allowed in, on the other end, studies that clearly didn't meet any evidentiary basis.
Yes,
these reports and things.
Yes, they took as their criteria. It had to be sort of a independently witnessed episode or video evidence of such, which is impossible.
Exactly.
So Vangean and Adamsbaum just got in as being modest sort of evidence.
And the other thing that I would point out is that an evidence-based review, evidence-based medicine was created and is used primarily for treatment. Evaluation of treatments, not diagnostic criteria. There's a different methodology that's used for diagnostic accuracy. But in this case, we readily admit that there's some degree of uncertainty and there's some degree of circularity. And we have tried mightily to exclude Tinahain's paper, one of her other papers, really tried very much to address that issue of circularity of reasoning, and still came up with the same conclusions and the same clinical manifestations of abusive head trauma.
Thank you.
Thank you.
It's a difficult problem.
Thank you.
Dr. Dice, I've got a few questions for you. Hopefully they are rapid fire, but maybe not. There are a number of very senior neurosurgeons in our participants. I can see Dr. Ludwig, who's the chair of the German pediatric neurosurgery, and Dr. Miroslav Jurasin. He's from Croatia, the leader of one of the leaders of pediatric neurosurgery there. So I will come back to them to ask whether they have any questions. I'm going to ask you a few questions in terms of delayed scalp swelling after head injury. And I had a patient when I was in one hospital, mother came 5 days after. She said that she only noticed it 5 days after, and there's a paper kicking around that you can see it. And I have had few other patients as well who came delayed swelling. What's your thoughts on that, please?
I think that absolutely is true and can happen. And I've seen multiple infants, and when I teach the residents, I always teach them to ask the parents, did the child have any trauma a week or two ago? Because the classic story, I'm sure this is what you're describing, classic story is the parent who is brushing the child's or washing the child's hair and notices this blottable collection under the scalp, and then brings it to the attention of their primary care provider or brings the child to the emergency room. They get an x-ray, and lo and behold, right? And then somebody...
Just a second. Okay. Yep.
And lo and behold, there's a skull fracture. And of course, everybody asks, was there any trauma? And the parent is thinking that day. So they say, well, no, there's no trauma. So I always tell the residents, always ask about trauma that occurred anytime in the last few weeks. And of course, children do things, especially children who are cruising or walking, do things that aren't witnessed. And so I think there could be minor injuries, a fall that results in a skull fracture where there's really not much generation of symptoms. Child may cry for a short period of time and then be consolable, or maybe the child's not even with somebody at the time or somebody immediately available. In any event, I've seen multiple cases where there's been some blottable. And by the way, when we get this subdural, this cephalohematoma, initially it doesn't, you don't feel it because it's not fluid yet. It's a clot. And so with hair and so on, you don't really notice it. It's kind of diffuse, and you don't notice a bump. And then 5 days later or a week later, when the blood is resolving, you get this blottable fluid, and that's when the parents notice it. So I think that's absolutely true. I think you can have that.
Thank you. The one thing that I initially found it difficult to have the concept, I think you touched on it and Mr. Edwards also mentioned it, this acute traumatic effusion. Could you just clarify that for the participants as well? What do you understand by this acute traumatic effusion?
So that has been, that's an entity that, so most of the time, when we have low density collections, they're chronic. We think of them as being chronic. But I think it's primarily Dr. Lee and the Korean groups have put this forth. And they've done some very interesting studies, mostly on adults, but the thought is that you can have an acute rupture of the arachnoid or tear in the arachnoid membrane that allows CSF to egress from the subarachnoid space between the arachnoid and the dura, and you get this, on occasion, you get acute dislocation of the CSF to the subarachnoid space, creating a more acute subdural hygroma or effusion. I think that's what you're talking about. Understand your question correctly.
Thanks, thank you. The other thing is that in terms of education, I come from originally, from Sri Lanka when I was a little lad, but I came here to Britain when I was 14. The concept of abuse is not even, people don't even know about it, first of all, abuse. And the second is that no one, come from a very educated family, educated society, but no one has the twinklest idea that shaking the baby will cause head injury. And the question is that how many parents actually shake the baby purposefully wanting to cause brain injury? If someone hits someone, they know that they are hurting a child. But when someone shakes the child, I'm just your thoughts on that, and also Mr. Edwards and Dr. Tebow, thanks.
Yeah, I mean, I think as I've heard people say, and I've said it, nobody gets up in the morning thinking I'm going to kill my baby today. And it's done. And most people describe a complete loss of control, mostly out of frustration and anger of a child who just will not stop crying. I've told this story numerous times when my daughter, or when my son was born, and my wife couldn't breastfeed, and so we were doing bottle feeds, and so I was getting up in the middle of the night to do bottle feeds. And this is actually where the prevention study that I did originated. And I was one time I was up with him, and I want to go back to sleep because I had to get up early in the morning and go do my job. And so I would try and get my son back down into the crib early before he was really asleep. And so I put him down in the crib really gently. And of course he'd do a morrow, and then he would wake up and he'd start crying again. And I pick him up and I rock him and walk around. And I remember distinctly one night, just 2 or 3 times he did that, and I was getting very frustrated with him. And I picked him up and I had him under his armpits, and I swear I did not shake my baby, but I picked him up and I was like, I looked at him, I said, "Would you please go to sleep?" And I thought, wow, all I have to do is increase my excursion, and I'm a perpetrator. I put him down and I walked into the room and I said to my wife, you got to get up and do this now. I can't do it anymore. I'm getting too frustrated. But I think people can actually lose their minds in response to this when they're dog tired, exhausted, and the child won't stop crying. I'm blocking on his name now, but there's somebody helped me with this, but he published a number of studies looking at discipline among parents all across the globe. And there's a fairly high incidence of people who admitted to shaking their babies out of frustration or for discipline. And in the United States, there is a certain proportion of people who admitted to it. And so, of course, the percentage who actually do it is probably much higher.
I think it goes. I mean, probably the most insightful thing, Naren, is the Adamsbaum paper from 2010, the French study, and this is a confessions paper, a bit controversial, but actually the way they compared confessions and non-confessions was very insightful, and a majority of the infants were shaken in frustration in response to crying, and I think it was about 40% of them were subject to repeated episodes of shaking, and often the caregivers I think perceived it almost as a benign thing. They described shaking in frustration to stop them crying, and then the baby became quiet, and they put them back in the crib, and then they woke up later, they were normal. And we would describe that as encephalopathic, probably obtunded, but to a lay caregiver, I suspect because the baby woke up and was apparently well, they perceived that as a perhaps potentially maybe even a non-harmful event, and it was only when the final event where the baby had a full encephalopathic collapse and didn't respond that they ended up in hospital, or the baby died, and then they end up in court. And I suspect that is a pattern that occurs, that and I suspect that a lot of even the repeated episodes of shaking may not all be sort of a malicious intent. I think some of them are definitely single losses of control. I think the mixed density collections, as Mark correctly pointed out, now generally perceived as arising potentially from a single episode of shaking, and don't necessarily reflect rebleeds into pre-existing collections and so on. A lot of this comes down to forensic detail. When you see babies that die after abusive head trauma, there are many pathological markers that can point to aging of the injury, and I think that's helped inform our understanding of these acute effusions, because you get evolution of the subdural membrane formation that occurs in a fairly predictable fashion, so you'll get the inner membrane of the subdural forms in the outer membrane, and then you get neovascularization of the membrane, and then these more friable vessels that have a tendency to rebleeding, and so for the forensics of this is the devil is really in the detail with these cases. I think it's
I do want to comment about just briefly about rebleeding. Some of you may know that Dr. Yashinsky in the United States has been a proponent of rebleeding and as a cause of acute deterioration in infants. And I do agree, rebleeding is fairly common. We showed that in our papers, and in every case, the rebleeding was asymptomatic after abusive head trauma. And so rebleeding does occur in a fairly common, fairly common, but it occurs over a reasonable period of time when there's neovascularization of the membrane and before the membrane becomes fibrous and sort of goes quiescent, almost like a quiescent volcano. But symptomatic rebleeding that causes catastrophic collapse, coma, or death really has not been described. And I took Dr. Yashinsky to the professional conduct committee of the AANS. And it was a fascinating a fascinating discussion amongst neurosurgeons led by Dr. Beam, who was fantastic. And I wish I could have recorded it, but I asked Dr. Yashinsky during that conference, and I also asked the three people who came to testify at the professional conduct committee on his behalf the same question. I said, can you point to a single peer-reviewed case of a child who suffered catastrophic collapse, coma, or death as a result of rebleeding into a chronic subdural? And none of them could cite a single case. And yet Dr. Yashinsky continued and continues to promulgate this idea that bouncing a baby on the knee can result in catastrophic collapse due to rebleeding.
I think fundamentally, Mark, I don't know whether, with a rebleed into a chronic subdural collection, you've got a membrane bound, it's enveloped, it's sealed off from the intracranial compartment effectively. So rebleeding should have a benign effect. The blood's not going to cause irritation. And what you do see, though, with repeated abuse cases that have died at postmortem, I've seen this on a number of occasions, is you have evidence, you may or may not have evidence of rebleeding into an old collection, but what you see on the post-mortem is fresh thin film subbleeding in a different location that cannot be explained by rebleeding. Rebleeding occurs into the compartmentalized, walled off subdural collection. So where you see fresh thin film bleeding, in the interhemispheric fissure where there's no related subdural, the bleeding occurs into the collection. It doesn't occur out into the it doesn't create a new subdural space, separate one.
Now, you're talking about rebleed, the sort of what I would refer to as benign rebleeding. Are you?
No, I'm talking about re-abuse. Re-abuse, yeah. So you get a different compartment or different thin film collection that's unrelated to the previous chronic subdural collection.
Yeah, that's a great point. Yeah, absolutely.
Question to Dr. Tebow.
I was just going to say, Mark, you've been too modest to mention your famous prevention study where you cut age down by almost 47%. It's become the basis of some of the some of the preventive studies that are now being rolled out across the UK. They are going to be subjected to a formal evaluation by the National Institute of Health Research, actually by a team from Bristol, as it happens. We put in a bid, but we failed. But it's a landmark study, and you've been too modest to mention it. Yeah. So I thought I'd mention it.
Well, thank you. I appreciate that. And for those of you who don't know, I started this study in upstate New York when I was there, and I should have stopped there because we showed by Poisson regression analysis that by comparing pre and post intervention that we have almost a 50% reduction in abusive head trauma cases, which had I stopped there, I would have been, a statue to me somewhere, right? Unfortunately, I moved to Penn State and I decided to replicate the study on a statewide level across all of Pennsylvania with CDC funding, and we found no difference. And so that's a much larger study, sort of negated the effect of the first. There's a bunch of different things and rationale that you could try. We were in the middle of the recession that started in 2008, which impacted results. And so there's a lot of things that you could say, maybe there were some modifying factors that may have explained that result. But when I got an award from the National Center on Abusive Head Trauma and for example, a Lifetime Achievement Award, which was wonderful, and I really appreciated it. I went out there and I said, I found this study, and then my subsequent study didn't showed that it didn't work, and also Des Runyon and Adam Zolator in their study in North Carolina using the period of purple crying also didn't show a benefit. And I said, my epitaph on my tombstone after I pass is going to be, at least he tried.
Yeah.
Dr. Tebow, can I, first of all, thanks for Dr. Tebow for bringing up this important work that Dr. Mark Dias has done. Thank you, Dr. Dias. Dr. Tebow, how much do the British parents know about the dangers of shaking? How well are they taught about this? And then new boyfriends come, who are not exactly the parents, the father of the child or mother of the child? What?
Yeah, it's very interesting. Very interesting question. It's difficult to answer. As I say, there's this program called Icons about trying to about infant, what to do when your infant cries. The program is trying to state that crying is a normal physiological event and what you should do and what you should do where it's just becoming unbearable. Just place the infant down and walk off. So that program is being sort of rolled out across the country. There have been various very small studies, one from Hampshire, for example, where it's been rolled out for some time, where again, it depends on treatment fidelity, how close people do stick to the actual ICON program. So in Hampshire, I think, and other areas, often the fathers who are the majority of the perpetrators, fathers didn't partake in it. It wasn't, and it was supposed to be done in the post antenatal period, and then immediately postnatal, and then the first health visitor visit, and then even at the 6-week visit. But often that didn't happen. But they did show some sort of not a proper outcome, but if you like a process evaluation where they looked at the parents that had been through it, and they found that, as Mark showed in his original study, that they were able to remember some of the messages about whatever you do, don't shake your infant. But that hasn't been translated into reduction in the overall prevalence. That'll have to wait for this much larger national NHIR funded study. So I think it's very, very patchy. It depends on the fidelity of how close people stick to the actual program, how available fathers are. Often they're not, particularly during the COVID period. Of course, they weren't even allowed to visit or be in the labour suite. So it's a very difficult question to answer, but hopefully in the next couple of years, through the Bristol team's work, we may get some answers.
Thanks, thank you. Just a social point is that I asked my mother, how come we never had, a child, as far as we knew, no case of child head injury or shaken baby syndrome, etc. And in Sri Lanka, northern Sri Lanka, a child is never left with a father to be looked after. A child is a property of the mother, and no mother will leave a child with a father to be babysit. So that's just an aside point. The other thing is I have worked in so many departments in the world and country. I think I probably hold the record by a mile. So this is something that I picked up in different places I have been, in terms of, a middle-aged parents comes with query, non-accidental injury. Usually that's kind of, it's not taken seriously. And if it's a, poor, racially disadvantaged community, everyone jumps on it. I'm just being generalizing. What's the statistics in America and in Britain in terms of how much the socioeconomics and the racial thing affecting the identification of non-accidental injury? Thanks.
That for me, in all countries, I think, a lot of the work's been done in the States, but again, in the UK, it's been shown there's a massive socioeconomic gradient. And often it has an ethnic gradient as well. And people have been suggesting there's some unconscious or conscious bias in reporting. But I think overall, I think it's related to poverty, and I think ethnicity perhaps is a proxy for living in severe poverty and very poor housing, and the relationship between poverty and poor housing. That there seems to be the major structural underpinnings of abuse in this country and in the States. The relationship between poverty and maltreatment is a very, very, very complex one. I have to say, but there's no doubt there's a massive socioeconomic gradient.
Thank you. Dr. Dias, what about the reporting? Does it change depending what race, what religion, or what socioeconomic background in states? Has this been looked at? I think it has.
It has. I mean, it's been looked at child abuse writ large, and also specifically with abusive head trauma. We did a study quite a while ago now, looking at New York. Looking at Pennsylvania, and on the demographics of abusive head trauma in Pennsylvania. And we did find exactly what other people have shown, that ethnicity makes a difference. I think it was mothers and fathers' age made a difference. Highest educational attainment made a difference. Of course, as Dr. Tebow says, those are all proxies for poverty, and also, I think it was smoking during pregnancy was another interesting covariate. But and as Dr. Tebow suggested, there is there's a real problem with, and that's been demonstrated a number of times in unconscious bias or with unconscious bias. I remember a study by Cindy Christian looking at bone fractures and showing that African American parents were much more commonly worked up for abuse in a child with a fracture, given the same circumstances than the parents of a white child. So clearly that feeds into it. Interestingly, I was just thinking about, again, this whole issue of prevention. Joanne Clevens looked at paid family leave and earned income tax credits in the US and showed a significant decline in abusive head trauma by making policy changes. And I must say, I'm not the most liberal person in the room, but when you look at data like that, you really have to take it seriously. If we can reduce child abuse through policy changes that support these kinds of families, I think we're sort of duty bound to do that.
Yeah. Thank you, Mr. Edwards. Did you want to make some point?
Well, one interesting thing, we did see a spike in NIHI and abusive head trauma in the lockdown period, particularly the first lockdown period, where I think families were forced together for prolonged periods of time. There were fiscal anxieties, maybe a lack of access to drugs and things like that in certain socioeconomic groups. And I think there are a lot of factors that sort of coalesce then to increase the sort of levels of frustration and loss of control in households with small babies. So I think that these are all difficult and thorny issues now, I don't think it's a problem that's necessarily going to go away. I think we can reduce the impact of it and educate families. I think going back to the comments about bias, my approach in Bristol is that any, as you've hopefully seen, any infant that's under the age of 1 with admitted accidental or non-accidental injury, we try and look at a feed and wrap MR scan if possible in all of them, and certainly fundi in all of them. And we did a small pilot study in ED departments and showed that only a very small proportion of babies get fundoscopy when they come in with minor head injury, and usually it's the ones that have a seizure or the ones that there may be other social concerns that get their fundi looked at. And the trouble is, this does raise the spectre of denominator bias, and my personal view is that there probably isn't a denominator, there isn't a bias. You probably are looking at things, but it's very difficult to prove without subjecting all of these infants to the same rule of thumb when you're investigating them. And I think the more liberal use of fundoscopic examination, particularly, I think would be helpful in accidental and non-accidental injury suspects, and potentially a bit more MRI imaging. I mean, what was most interesting was the 3 studies, one by Rooks, one by Whitby, looking at newborn babies, where they identified, a very high incidence. In one series, up to 40% of infants had these intradural bleeds in the post-fossa and occipital region. And so again, in early infancy, you've got to be quite careful about attributing, isolated subdural collections to abusive head trauma, and it's really important you look at the whole picture. There are other features that support that as a diagnosis, and again, none of those studies I think demonstrated any significant frontal subdural collection. So if you've got those with an uncomplicated birth history, it's far more likely to be abusive injury. And so the level of forensic scrutiny you need to apply to these cases is enormous, I think, and particularly with the demands of the courts now to really put expert witnesses under the microscope when you're giving evidence. You've really got to know your stuff, and a lot of cases fall down because of a lack of a forensic approach by the clinical team. So I think the more thorough you are in documenting things, the more comprehensive your protocols are for investigating, rule out medical diagnoses as well. The more likely you are to get the right answer when they go to court. But most units have a workup for conditions to be excluded in abusive head trauma, and that list grows longer every day. But it is quite an important one, and particularly things like hematological disorders and things like that. It does get quite difficult going into court and arguing that a multifocal thin film subdural is not something you see actually in coagulopathies, for example. That's not the pattern of bleeding, but then you're having to argue a pattern of bleeding rather than saying, here's the blood test, it's normal, this kid doesn't have a rare clotting abnormality. So I think for the stalwarts who stuck to the end of this conversation, have a good protocol for investigating these babies, and make sure that that's the pediatricians in your service complete that, so you've got that forensic evidence.
Thanks. Last two questions. I'll be quick. In terms of the patients with enlarged subarachnoid spaces and to lesser extent with arachnoid cysts, how many of them have you then subsequently seen subdurals in infancy, and your advice for the parents? Because sometimes when I advise parents, I'm always advising them, look, be careful with your child, because if there's a bleed with a child with a enlarged subarachnoid space, then it will be always has to be excluded NAI. And the other, on the corollary, if parents did not know that there was an enlarged subarachnoid space and then they come present with the subdural, but as you mentioned, they are going to be less severe clinically. So your thoughts, Dr. Dias? Thanks.
I'm not sure what the question was.
The question is that how do you advise parents with the children with enlarged subarachnoid spaces in terms of how careful that they need to manage their children to avoid subdural stents?
Yeah, I tell them that it's very rare, but I tell them up front. I tell them, so this is a benign condition and almost never requires treatment for what is essentially an external hydrocephalus. But I always tell them, I say, there are a small number, about 2% of these children, who will get bleeding around the outside of the brain, and it's not consequential in terms of the child, but it will raise the question about abusive trauma. And so I'm upfront with them right from the get-go, and I say, just be aware of this. And so if your child is found to have a subdural later by somebody else, make sure you understand that you let them know that Dr. Diaz said this occurs about 2% of the time, because not everybody's aware of these studies. But I also tell them, you probably ought to be a little more careful about bouncing the child on your knee, tossing the child in the air. And I tell them, I tossed my children when they were infants into the air and, caught them and so on, and they giggled and laughed and it was fun. But I tell them, because of this condition, you probably should avoid doing things like that.
Thank you. Just a question on the surgical side of things. If there's a large subdural collection and you eventually end up putting a drain, do you put a valve or not to put a valve? And if you don't put a valve, do you later on put a valve? And if the brain doesn't expand, do you then put a ventricular catheter and connect to the subdural catheter? How do you manage these patients with large subdural collections?
Generally, I try not to. First of all, I generally try not to treat them if the child's asymptomatic. I try and give them some time for it to resolve. And I've seen several of these children with growing subdurals that eventually got smaller and went away. And so giving them some tincture of time. If I treat them, I usually treat them with a valveless system. It's extra arachnoid typically, right? In these chronic collections. And so I just do a straight tube without a valve. I put a tapping chamber in line just in case there's a question of infection later, but I don't use a valve. Yeah, I've not had the circumstance, I don't think, where the brain has failed to expand. I don't know. I don't know that. Certainly, I don't think I would put a ventricular catheter in and tee it into the system.
Thank you.
I don't want to drain the CSF collection, the CSF, thinking that might make the subdural effusion larger.
Sure. Mr. Edwards, have you ever had to tee a ventricular catheter into a subdural peritoneal drain?
We do that with only in case of hydrocephalus where you've got subdural collections, but I mean these babies have isolated subdural collections. So sometimes most of the time they're managed with taps, and to be honest, you just need to tap them until the brain starts to shrink often, and then they may be left with some hygromas. I don't know whether you shunt them anyway, Mark, but you know, I think usually they don't exert mass effect after a period of time, and they can be managed conservatively. I think every now and again you get one that needs a subdural peritoneal shunt, but it's not common. But
I agree. I think a lot of these, if their head's not accelerating or their fontanelle's not full and they're not symptomatic, I generally am very conservative about treating those.
Yeah. Our daily head circumference is very useful with these, again, from a forensic perspective as well, because you see this big spike in head growth in the first few days after the injury, and then it levels off as this it gets a more equilibrium. But you know, it's good.
Thank you, Dr. Dibble. Just this is the last final. Any other comments, Dr. Dibble, before I ask Mr. Richard Edwards to give the?
Thanks very much, Naren, for organising it. It's been absolutely fascinating. I've learned so much. It's been great. Thank you. Thanks very much. Indeed.
Thank you both for your comments as well. They've been very, very helpful, I think. And in addition, the discussion's been very enlightening.
Thank you, Mr. Edwards. Could you please make the closing?
Well, I just like to thank Marco. It's a real pleasure to listen to you talk on this. You're an absolute opinion leader in this field, and you know, it's been a real privilege to share the platform and ask you some questions. So thank you.
Thank you. And thanks to everybody who has managed to stay on over almost 2.5 hours. It's amazing.
I think I only said what's the start time. I don't think I said the end time. So thank you very much, Dr. Dice. I think that's one of those nice things about these meetings is that, you know, you can actually examine it insightfully. So that is as much useful. So great honor to have Dr. Mark Dice with us and for this fantastic lecture. It's already available online on YouTube. Thank you very much to Mr. Edwards and Mr. Dr. Dibble for these insightful discussions. And those who wish to get a certificate of attendance, I have put the link on the chat box. If you click on that, then you will, you have to just fill in your name and email address, and automatically a certificate of attendance will be sent to you. Thank you very much, and wishing you all a wonderful weekend, and see you again soon. Thanks. Bye for now.
Bye-bye.
Thank you. Bye-bye.
Thank you. Bye.